Good evening, everyone. I'm Dr. Manjit, HOD Pathology, AIMS Bathinda, and I have been working in this area from last 13 years, and this topic is near to my heart, and I had been working in this area, so I'll try to express rather my feelings to my lecture. So I'll start with my lecture. So it's the molecular subtyping of carcinoma breast, the present and the future of the typing. So starting from the basic of the carcinoma breast, as we know, it's the most common carcinoma worldwide now, and arising from the ducts of the breast or can be from the lobules. So sometimes we say it's from the lobular carcinoma arising from the lobules, but actually the terms are misnomer. Duct carcinoma, lobular carcinoma can arise from any part of the breast. And in 2020, before that, we were thinking about like CA cervix is more common in the female. But now, CA breast has surpassed all the carcinomas, and it's a worldwide most common carcinoma in the female now. So global burden, you can see that it will cross the limits. It will cross almost 2 million by 2030. And initially we used to say that it's a carcinoma of the developed countries and because of their lifestyle, but now maybe we are adapting that lifestyle in the developing country also, and carcinoma is now first most common amongst all carcinoma in female. But in addition to that, what we have seen that there is tumor heterogeneity also, because there is a difference in the presentation, there is difference in the molecular origin of the carcinoma, molecular presentation of the carcinoma. So that may be the reason in addition to westernization of the culture. So that's why molecular profiling, molecular typing of the breast carcinoma is more important nowadays, and everyone should know about this. And before I discuss the molecular typing or profiling of the carcinoma, we know that in this carcinoma, please, okay, approach should always be multidisciplinary, and although in some outside the institute sometimes it's not possible, but should be multidisciplinary with the combination of oncologists, radiologists, surgeons, surgical oncologists, and pathologists. And when we talk about the treatment part or the management part under the tumor board, these are the traditional prognostic markers that currently exist. So the traditional prognostic or predictive markers are histological type. If it is IDC, then definitely high grade is more risky. If it is mucinous carcinoma, histopathological type, prognosis is good, patient will have good survival, so depending upon that. If in the carcinoma breast, there is more extensive component of DCIS, when we see the report of CA breast, if we see extensive component of DCIS, then also the prognosis is bad in the patient. And lymphatic invasion, vascular invasion, whenever see this in the histopathological report, even without metastatic deposits in the lymph node, the prognosis of the patient will be bad in this case. And microcalcifications definitely will lead on to the bad prognosis. And next important part is the breast biomarker reporting that will report molecular profiling. So under this, what commonly we should see in the CA breast, because the CA breast is related with the hormonal expression. So we will look for the it's very normal, everybody is knowing this, that we will look for the ERPR, and we will look for the HER2, we will look for the Ki67 expression. So when we talk about the ER expression, so we have 5 grades depending upon the number of cells stained with the ER, or number of cells expressing the ER expression amongst whole of the tumor along with the staining of the cells. So in clinicians' knowledge, you can see from left to right, we have tumor cells in the blue color. And with the increase of the expression of the ER, we are seeing in the third number, there's little expression of the ER. In the 4, there's more 5. Then ultimately, whole of the tumor is showing expression of the ER. Same is with the PR. So what is the meaning of this? So currently we are using this. So what is the meaning of this? It means that if we talk about the last one, 100%, so patient will have 100% response to the tamoxifen. That is the meaning of the profiling, what we do for the molecular profiling. The patient will respond 100% to the ER. In the 0 expression, patient will not respond at all to the ER expression, and patient will have a bad prognosis. Same is with the expression of the stain. So this is section has been taken from the tumor of the tissue. We can see that all the tumor cells are showing brown expression in the A, and in the B there are lesser number of cells. Approximately 60 to 70% cells are showing expression for the ER. Means on the A side, 100% chances are there for response to the tamoxifen, and on the B side, patient will have 60 to 70% chances for response to the tumors tamoxifen. Next is the HER2 new testing. So this is the present of the molecular profiling, present scenario of the molecular profiling. HER2 new testing, we know that HER2 is important for the breast carcinoma. If it is HER2 positive, we have to go for the FISH testing. FISH amplification is very, very important. Although it's a costly test, needs expertise, and it should be done. And FISH is gold standard for this. If HER2 is 3 positive, that means patient is again can have a medicine targeted therapy, and patient will respond to the treatment. So this is just to show how color of the or scoring of the HER2 will be done. But the important is the molecular profiling. This is the 5 intrinsic molecular classes of the breast carcinoma. Luminal A, starting with the luminal A to the triple negative. I'll not repeat all those what I have discussed, but there are 5 different classifications for the molecular classification or molecular profiling for the breast carcinoma. Starting with the luminal A, when ER/PR is positive, patient will have a good prognosis, and KI 67 is the proliferation marker. This should be applied. Sometimes we get reports done from the outside. We see that there is no KI 67 applied. So that should be applied, and molecular classification should be done in the patient of carcinoma breast. So low expression of KI means good prognosis, means proliferation is less, prognosis is good. When we go downwards, in the second last, there is HER2 enriched molecular profiling. Definitely patient is ER/PR negative and HER2 positive. Last one is very dangerous, that is triple negative, and approximately 50 to 20% of the patient lie in this area. There is no ER expression, there is no HER2 expression, there is no any other treatment than simple chemotherapy. So in this, patient will definitely have a very bad prognosis. So this is the present scenario. We have to go for ER, we have to go for PR, we have to do HER2 new, KI67. If HER2 is 2+, we have to go with the FISH. So this is a simple explanation of the molecular profile, what we see under this molecular profile. There are 5 types of classification of carcinoma breast under molecular profiling. This is what we have to do in future. Currently we are working on this. As we see in the first row, currently we know that ER/PR positive, give tamoxifen. If patient is HER2 positive, give medicine, okay? But what will happen to the triple negative breast patients? The triple negative patients in the second last row, you can see that this one, the genomic subtypes, This genomic subtypes depends upon the what type of gene is present in the patient. BL1 basically stands for the basal-like, BL1, BL2, M, MS, IM, immunomodular type, LAR, and UNS. So from this, in the genomic profiling, further, in the BL1, BL2, we have basal-like carcinoma in the triple negative. So chemotherapy is being given to these patients. M and MS, there are metaplastic carcinoma. This metaplastic carcinoma can be identified even on the histopathological examination, and prognosis is bad. So prognosis is bad in BL1, BL2, M and MS in case of triple negative breast carcinomas. Okay, so in the IM and LAR, medullary carcinoma, luminal AR. Luminal AR is androgen receptive. Means this type of breast carcinoma is responding to the male hormones. So luminal AR is also there. Adenocystic carcinoma. So these carcinoma, they have less aggressive prognosis under the category of TNBC. So more problematic is UNS. UNS is unstable type of genome. So this should be the future of breast carcinoma. This should be the area of research in case of breast carcinoma. So what are the new lesions? People are working on these genomes, but as you can see that there are two type of factors are there always in carcinoma. One is prognostic, one is predictive. In prognostic, we can say that, okay, B1, BL2, they have aggressive prognosis. IM and LAR genome, if patient will have bad prognosis or good prognosis than, BL1 and BL2. But what about the prognostic markers? Predictive markers. Predictive marker means, can we develop treatment for these patients? Can we modify these factors? So yes, we can modify the factors for UNS patients, these patients, and also some other patients who are triple negative. So new addition was done by the American College of Pathologists. They have given now new classification because in case of low positive, ER positive tumor cells. Because when we classify ER positive tumor cells of breast carcinoma, we always give negative when there is only 1 to 10% expression of the ER in a breast cancer. Okay, now they have done the trial and they got to know that even in case of 1 to 10% of the cells staining positive for ER or giving expression of the ER, we can label that patient as low positive for ER, and we can give tamoxifen or we can modify the targeted therapy. So this is the future of the molecular profiling, and these patients are eligible for the endocrine treatment, means hormonal treatment. And in addition to that, very nice addition is in the Destiny clinical trials. So these the sixth trial now is going on, and under this, currently even in the present scenario, what we are doing is HER2 positive, 3 positive, 2 positive. इससे ज़्यादा we are not doing anything. But the patient who were score HER2 positive or FISH negative, we were ignoring those patients and we were categorizing those patients in the triple negative. But now the Destiny trials, they have said that we can categorize these HER2 low patients under HER2 low. We can categorize HER2 ultra low. So we can give now therapy to these patients also. So this is the addition in the current molecular profiling of the carcinoma breast, and this will be soon come under the NCCN guidelines and will be applied to the patients, and this will save the patient further, especially triple negative carcinoma breast patients. So this is about the unstable type of genome that comes under the triple negative. So PARP therapy, it's a PARP, sorry for the mistake. inhibitors are being developed and that will be given to these patients, and trials are going on and showing good response. So this is just our experience, because whenever you are doing molecular profiling, you must have some external quality assurance program. You have to get registered somewhere so that you can get to know that the profiling what you are reporting is good or not. So our department is enrolled under National Cancer Grid under TMH Mumbai by Government of India. And as I told you that I have been working in CA breast, and I had explained many a times to ICMR that there is huge tumor heterogeneity in this area. So because of that, they have given some funds to us, and we are working on this. And this is the data currently what we have got to know about this area. And good thing is that in our area, patients are presenting in stage 2, in the early stage. And patients currently, in comparison to rest of the India, our recurrence rate is now less because patients are getting treated well. So this is just to show the histopathological examination. If any pathologist is there, that person can appreciate. So luminal A type of carcinoma. This is luminal B type of carcinoma. And the different profile under luminal B, HER2 positive. And this one is luminal B, non-invasive, non-luminal type. And this one is triple negative. But in the D, you can see high proliferation positive for the Ki67. So definitely there will be bad prognosis. In these kind of patients, we can go for the low ER positivity. We can check HER2 low, we can check HER2 ultra low, and we can check unstable genome. So 3 possibilities are now available for triple negative breast carcinoma patients. So this is the new addition. This is being done in our department because FISH is a costly test in the HER2 cases and need expertise also. So we have one automated equipment, and with the help of that, we can do DISH. DISH is an alternative of the FISH. So this is our data in comparison with the other studies done in India and in joining countries. So in our scenario, we have more luminal B type type of carcinomas, and we have relatively lesser number of triple negative breast cancer patients in respect to other parts of India. So in addition to new additions, we can go with BRC, BRCA gene testing, NGS, Oncotype DX also. This is currently in use. Oncotype DX is just a simple test. With this, we can check that this patient will have metastasis in future or not, whether this patient requires chemotherapy or not. So on the basis of this, radiation oncologist or oncologist, they can decide that whether chemotherapy is required or not. And liquid biopsies are under trial only. So these are the future directions. So the personalized medicines, they can tailor the healthcare strategies to individualize the genetic profiling, increasing the effectiveness and efficacy of the treatments. So currently, we have new additions in the molecular profiling, ER low positive, HER2 low positive, and HER2 ultra low positive, along with unstable genome. Thank you. Thank you very much.